Welcome to Grand Rounds, September 2024. Just because today is 9/11, so just out of respect, I want to offer a moment of silence for the people we lost 23 years ago. Right. So today we have the opportunity to hear about augmentative and alternative communication, and apparently I need that because I can't even speak to say it. The principles of speech generating devices, evaluation, and treatment. So today we have Deven Knox and Alexandra Newins, and if I can pull this up, there we go. Ms. Knox is a pediatric speech-language pathologist who specializes in working with bilingual Spanish and English patients and patients with complex communication needs. She received a Bachelor of Arts in Speech, Language, and Hearing and a Bachelor of Arts in Spanish from Temple University. She received her Master's of Arts in Speech-Language Pathology degree from George Washington University. During her graduate studies, she became passionate about the use of alternative and augmentative communication for individuals with complex communication needs. Ms. Knox received a graduate certificate in assistive technology from George Mason University to further her education in assistive technology and AAC. To further her education and expertise, Deven also received a certificate in Bilingual Extension Institute, Speech Language Pathology Teachers College of Columbia University in December 2023. In her practice, she is passionate about providing holistic team-based treatment that is individualized to her patients' needs. Ms. Newins obtained her Bachelor of Science and Master's of Science in Speech Language Pathology degree from Misericordia University. She currently holds her Certificate of Clinical Competence from the American Speech and Language Hearing Association. She is trained in prompt for motor speech disorders and childhood apraxia of speech, and she is trained in high-tech communication devices such as Tobii Dynavox, SmartBox, and PRC Saltillo products. Ms. Newins also has an interest in parent-child coaching and is licensed in It Takes Two to Talk and 4 Eyes to Socialize from the Hannon Center. She often uses these specific approaches to work collaboratively with patients or with parents in their child's speech therapy sessions to ensure that the family knows how to help their child reach and exceed his or her speech and language goals through a coaching model. So just the normal things you need to do: make sure you sign in. Make sure when this presentation is over, you complete the quiz and complete the evaluation to get the appropriate CE or CME credit. Also for ASHA, make sure you fill in your bubble forms appropriately. So without further ado, I will turn it over to Ms. Knox.
Hello, everyone. Thank you for joining us this afternoon. I'm Deven.
And I'm Alex.
And we are going to be presenting Foundations of Augmentative and Alternative Communication, Principles of Speech Generating Device Evaluation and Treatment today. Maybe. There we go. Okay, I'll just click. All right, so for the first few slides, just some general information to describe what we're going to be talking about today and why it's important. So today, we really hope that after our presentation, our participants will be able to leave this with a good wealth of knowledge of evidence-based practices when it comes to AAC. So we're hoping our participants will be able to create effective treatment plans, provide those evaluations, and also have those strong clinical decision-making skills in order to fulfill this whole process. So we're really hoping that we'll also be able to integrate the use of AAC into our therapy practice with our individuals who do have complex communication needs. So here's the designation statement. As Steve said, there are CEUs available with this course. If you have any questions, please feel free to ask Steve. Our disclosure information, Alex and I have no financial relationships to disclose. We will be referencing specific companies today. Those are just examples. We have no financial relationships with these companies. We're just mentioning them as examples. So as said before, these are a few of the things that we hope that you come out of this presentation having. So we're hoping that our participants will recognize and implement best practice and evidence-based practice when assessing and treating those patients who utilize AAC, and also be able to discuss the best practice. Participants will also be able to execute evidence-based treatment and design evidence-based treatment plans for those AAC users. So AAC, I've said it a lot, but what is it? A lot of the participants who've tuned in who are speech language pathologists are probably very familiar with this term. It's augmentative and alternative communication. Going forward, we're just going to refer to it as AAC. It's a lot quicker. Usually when we think about AAC, we're thinking about our high technology and dynamic display devices. So those are speech generating, and those high tech devices tend to be those tablet-based devices that have software to them. Dynamic display means that when you touch an icon on one screen, it moves to another screen or things change. It's dynamic. It also has that speech generating output. So when you press an icon or press the sentence, it generates the speech for the user. Alex and I sent out a survey to the speech language pathologists in the network a few months ago, and a lot of the responses we received highlighted a need for information regarding mid-technology and light technology devices. So mid-technology devices do have speech output, but they are non-dynamic display. So they're considered static display devices. Usually they're battery operated and not tablet-based. So think about those green Go Talks, and also think about those Big Mac switches, those one message hit switches. For light tech, we used to call it low tech, but a lot of the literature now refers to it as light tech. So during this presentation, we're going to try to refer to it as light tech. Light tech is no voice output, no technology component to it. So there's no battery operation, nothing to charge. Those are typically our paper-based systems. So that's that picture exchange system or a core board. So the big question, who benefits from AAC? There are no prerequisites for using AAC. Alex is going to dive way deeper into this later in our presentation, but we want to continue to highlight that as we go through our presentation. There are no prerequisites for alternative and augmentative communication. Our patients do not need to be demonstrating any level of skills cognitively, physically, or linguistically in order to be a really great candidate for AAC. So a lot of times with our AAC, we're thinking of our patients who are non-speaking or who verbal communication is not an effective method to communicate their wants and needs. This could be for a variety of reasons. This could be due to aphasia, post-stroke, or traumatic brain injury. We also could think of individuals who have a speech motor disorder, dysarthria, apraxia. And there's also a few of those patients that we might not think about immediately. So we might think of patients who have who are dysregulated and utilize vocal stimulation to regulate their sensory system. I had a patient prior who utilized vocalizations to calm himself and to self-stimulate. And because of this, his mouth wasn't always available for verbal communication. But with the use of AAC, he could continue to regulate his sensory system with those vocalizations and communicate with the device. We also might think of those just salt language processors. Alex always says that she could make an entire grand rounds just about this, but those AAC devices can really help that type of language processor build on those functional communication phrases that they have. So once we've determined the individuals that would benefit from the use of AAC, now we want to think about what we have to do for the rest of the process. So those major considerations. First and foremost, and throughout this presentation, we're going to continue to highlight it. The user is our number one consideration. Their needs and their preferences are number one. It is their device. It is their voice. We have to honor what they want. Within that, we need to consider those environmental factors. They're usually with us 1 to 2 times a week for 45 minutes. There's a whole life that they live outside of therapy, and we need to think about that life. We need to make considerations regarding what software and hardware will best fit with them. And going with that environmental factor, we need to continue to receive and take feedback from caregivers and users, as they are a big part of this AAC team. And finally, we need to keep in mind those trainings that we will continue to do for caregivers and for users, as we want this to generalize outside of therapy. So we need to continue to think about those trainings that we'll provide. Hardware types. So when we're talking about speech generating devices, typically we're talking about 2 areas. We're talking about the hardware and the software. So the hardware is the physical device that you hold in your hand. And there's 2 different kinds of hardware. There's direct select and indirect select. So direct select is the user is directly touching the device, whether they're touching their device with a finger, a stylus, potentially touching the device with their eye gaze, head tracking, or a laser pointer. We could also think of like a head stick, which is a device that could attach to a headband, and then the patient uses it to access the icon. Indirect select is the patient is not directly touching the device. There is another middleman, almost technology, that is being used to access the device. These are the switches and scanning technologies, and potentially also a partner-assisted scanning. So to get a little bit more into these access methods, there are multiple different kinds of access methods, but we're going to talk about 4 main types today. So one of the main types of access is eye gaze. So that's the direct selection utilizing our eyes with a device that is embedded in the speech generating device that tracks eye movement. We then have the switch scanning, which is the indirect selection, and a patient might use, for example, we'll talk about the jelly bean switches. They might press the button for once to start scanning through each icon on the device, and the patient might access the same switch or another switch to stop and communicate to the technology that is the icon that I wish to communicate. We then have partner-assisted scanning, which allows partners, the communication partner, to talk through potentially each icon and have a designated communication method with the communicator of when to stop and to select that icon. We then have touch selection. So again, that could be with a variety of tools. Usually we think of a finger, but there are other tools we could use for touch selection where the patient and user is directly touching the icon on the device. So here we have a few of those hardware device examples. So we have that green Go Talk, that's that static display. We have 2 examples of the dynamic display systems that we think about a lot, but we also have that LightTech core board, which is a very important part of AAC and still needs to be considered when we are thinking about AAC. Here we have a variety of switch examples. So switches can come in all shapes and forms and can be accessed from almost any part of the body. So we could have a joystick, a head switch, a hand switch, or even like a puff and sip switch that can be operated with the user's mouth to access the speech generating device.
Okay, great. So now we are going to talk all about software. And we wanted to highlight the difference between an iOS-based application and then the vocabulary you might use when recommending a dedicated device. You can see some examples here about the iOS-based applications. But when we go to recommend that dedicated device, we're going to talk about the hardware and the software. And many of these companies have specific names for the software because it is that dedicated device. Many insurance companies do not cover an iPad, And so we want to make sure that we're using the right terminology. And when I first started out with AAC, I felt like I needed to get a handle on all of these names of the softwares and hardwares. So we just recommend looking at the website and the products listed, and then there you can clearly see the hardware and the software names. So for example, on our clinic iPads, we often use TouchChat. That's an iOS-based software, an application. But when you go to recommend that dedicated device, you're going to be calling it a NovaChat. A NovaChat is actually a Samsung-based tablet, and it has its own NovaChat software. And so you just want to make sure that you're differentiating between the vocabulary. Thinking about our evaluation process and specifically in relation to software, we're going to be thinking about feature matching. And that is just making sure we're aligning the needs of our user to the hardware and the software. And we want to keep in mind, one size does not fit all. And so we can think about vision, cognitive and linguistic skills, physical and motor skills. But this idea of one size does not fit all is we really want to be considering each of the features of the softwares and then pairing that with the device that we're going to select for our patient. And I personally feel like I got very comfortable with TouchChat when I was first starting out with AAC. I found that it was easy to navigate and that my patients picked up on it pretty quickly. And so I got into the habit of recommending or starting with it first. But now that I learned a little bit more about the software features of different applications, I feel like it's a little bit easier to feature match and pick one that might fit my patient's skills, keeping in mind the vision, the cognition, the physical motor skills. Thinking about prerequisites for high-tech AAC, Deven mentioned before, there's no hierarchical progression required. So I think we have a great list of these prerequisite myths on this slide. And prior knowledge in the AAC world, believed that our patients needed to demonstrate certain amount of skills before we started with high-tech AAC. Maybe they needed to show us to understand cause and effect, or that they needed to demonstrate use of PECS or sign, and they had to have a good handle on those cognitive and language skills. But now we would really recommend, and we think it's best practice, to introduce AAC alongside all of those other communication methods and use that total communication approach. In the next few slides, we're going to talk about the different softwares and then the considerations that you can use to pick the best one for your patients. So when we're talking about that feature matching process, how do we pick which software to start with our patients? So the first type of navigation I'm going to talk about is linguistic-based navigation. We can find that on, for example, on a SuperCore 50 in Grid, or you could also consider that TouchChat. And this navigation is based on semantic categories or syntactic categories. Pretty much every vocabulary word on the device is divided up into a category. So if your patient demonstrates strong receptive language skills and those receptive language skills outweigh the expressive skills, this could be a great consideration for them. Also, I like to consider this software if the caregivers are hesitant about buying into AAC. I feel like it's really easy to navigate with those categories, and you can find those fringe vocabulary words a little bit easier on this type of software. So if you need the parents to be modeling more at home, this is a great app to start with in your trials. Next, I'm going to talk about motor planning-based navigation. So whenever I think about motor planning, I think about LAMP, language acquisition through motor planning. It's in the name of the software. And when I consider this application, I think about my patients who learn best from routine and repetition. I have a lot of patients that come in and they like the same sequence of games or activities or toys. And those are the patients that would even benefit from the same motor plan to access equipment from a gross motor standpoint. So you could consider that when you're thinking about starting with AAC. If your patient learns best from that routine, maybe start with a LAMP. LAMP is organized by word association versus those categorical symbols that we were talking about in the linguistic-based navigation. So, for example, on the homepage for LAMP, you see the Eat button, which is an apple icon. And when you select that, the vocabulary that opens up are all words associated with an apple. It could be eat, read, fruit, bite, and hungry. And when we think about language processing, and especially receptive language, word associations develop before categorical receptive language skills. So I like to consider this for my patients who may have receptive language deficits. Also, this type of navigation requires consistent placement of the symbols, and that makes it easier for motor recall. And you can consider that for visual challenges or those cognitive processing challenges. Next, we're going to talk about environmentally based navigation. So the example on this slide is Toby Dynavac's SNAP, and then specifically the Quick Fires folder under SNAP. And I might consider this if my patient demonstrates cognitive challenges. There's a certain ease that comes along with the vocabulary organized into folders based on the context of their environment or the activity. And if your patient is really, it's a strength that they can recognize the environment and the context, then you might consider an app or a software like this. Also, it has that quick phrase-based communication. So if your patient requires access to a phrase because of motor access or motor difficulties accessing the device, it's easier to select one button that has a phrase rather than selecting 3 buttons to build that same phrase. And then also of note, our GLP patients, we know that they really, really learn and grow with the use of phrases. And so this is one example of an application that already has a ton of pre-programmed phrases in the software. And then next, pragmatic-based navigation. So the example here is VocoChat in Grid, and we also have Pod and TD Snap, and that's also available in Grid. And then you can think about Lingraphica Hub, the Talk application. So these are pragmatic-based navigation systems are usually larger cells that are separated into folders based on communication functions. So when we think about communication functions, we think about the ability to request, comment, ask a question, tell a joke. So you might use this with a patient that has a really good understanding and they use a lot of those different functions, but they just need words to associate with those functions. Usually these applications or softwares have larger cells, so you might think about this for a patient with complex access needs as well. In any of these softwares, we're going to be considering grid size as part of our evaluation. And Deven and I really wanted to impress upon everyone listening about the idea of robust vocabulary. And when we think about a robust vocabulary, we think of a vocabulary that will allow our patient to learn and grow with it. And it provides an ease of access to a lot of different vocabulary words at a time. So we want to make sure we're choosing our grid size based on what we know the AAC learner can see and touch. I think a lot about my patients who are so tech savvy nowadays. They have iPads or they have their parents' phones and they're in the waiting room and they're navigating Netflix or YouTube on a very small screen. And so I think about that when I'm thinking about their access to a screen that's maybe 10 or 12 inches. And so if they're able to hit the play button on a YouTube screen, then we know that they're able to access smaller buttons on a grid size for an AC device. So we want to be cautious about starting with bigger buttons. When I first started with AAC, and I know Deven said the same, we thought maybe it would be easier to start maybe with 4 buttons, more, stop, all done and go. And then, you know, our patients that might have attention challenges, it would be easier for them to see the buttons. And they did great with it and they would show fast success. And then all of a sudden we want to add more vocabulary on. And then we realized there was like a pause in progress because they had to learn a whole new motor plan. So I like this from your bilingual standpoint. Software is like learning a new language. Every grid size or vocabulary set is a different language. So we want to keep that in mind and start with a bigger size so that they don't have to keep relearning this language. So here's an example of TouchChat Word Power 60 Basic on the left, and then this is a very robust vocabulary system, lots of access to vocabulary right on the home page. But sometimes it can be a lot for parents to look at, or even our patients with visual or attention deficits. So you can edit it down, you can hide buttons, and you can make it more accessible for those patients, but then allow them to learn and grow by just showing more buttons or adding more buttons on as they learn more vocabulary.
So once we've kind of thought about the software, and I'll preface that by saying that between hardware considerations and software considerations, you don't really need to start with one over the other when you're doing this process. So many of the device companies have every software on every hardware, and a lot of them now have other companies' softwares on their hardwares. So you don't necessarily need to do software before hardware or hardware before software. Follow the patient's needs. So if you find that this patient is going to need a very specific kind of hardware, maybe that's where you'll start. If you have a patient that can access a variety of hardwares, then maybe you'll start with software. But again, a lot of these device companies have all of these softwares on so many different hardwares. So you can kind of choose where you want to start. So for hardware considerations, there's really three main things we want to think about. So we want to start with thinking about the patient's gross motor skills. So we want to think, is the patient a wheelchair user, or does the patient use another mobility device to assist with walking? Because if we're thinking about that, we're going to have to think about mounting the device. And when we're thinking about mounting the device, we want to make sure we know that before we go into the insurance request, because we want to make sure that the device company we're going through has the appropriate mounting for the wheelchair that the patient uses. This is going to be where our physical therapists and our seating and mobility specialists are really going to support us as the speech therapists in some of these decision making, because they're going to assist us with what our patients' gross motor needs are and where they have the most motoric control. So as we said prior regarding the switches, you can put a switch anywhere, and a switch, there are Bluetooth switches now, so it doesn't even need to be a wired switch to a device. So you can have a pedal switch with the feet, as pictured here. You can have a head switch, but you're going to need to know where the patient has the most motoric control and where they feel the most comfortable placing that switch access. So that's where our physical therapists and occupational therapists will really support in these hardware selections. Something you're going to see a lot in the next few slides is eye gaze. Eye gaze is a really great option for our patients where using their hands might not be the best option all the time. A lot of times with these eye gaze devices, finger selection or stylus selection is still an option. So you can use eye gaze and the finger at the same time to access the device. So eye gaze is it's just a great option for our patients who might have some fine and gross motor deficits. So when we're thinking about our fine motor skills, a lot of times when we are accessing a speech generating device that is direct select, we're using that finger isolation. So if a patient requires assistance with that finger isolation and has fine motor deficits, we want to be involving our occupational therapists into these considerations. So we might be considering a brace in order to isolate the finger for the user. We also might consider key guards versus touch guides. Key guard is the picture that is up top, the yellow with the pink case, and the touch guide is on the lower area with the blue case. Key guard, the biggest difference is just has a larger area for the icon, whereas the touch guide is just a smaller access point for the key. We also might consider eye gaze for our individuals who have fine motor deficits, where they can utilize their eyes to access the device, but maybe not their hands, and so that might be the best. Something else we can consider is device size and grid size. So a lot of these devices come in a variety of screen sizes. You can get a device now that is the size of an iPhone. You can also get a device that is about the size of a computer monitor. So, and everything in between. So a lot of times we think about that iPad size, about, I think it's 10 to 12 inches. But they come in a variety of sizes. So if we have an individual who has a fine motor deficit and needs a physically larger key to access, but as Alex said, we don't want to decrease that robust vocabulary, well, we might just think about making the device bigger so that the icons are naturally bigger. We also might have to consider grid size. As much as we do state, go with that robust grid size. Remember, we're thinking about the patient as the whole body and the whole person. We have to make sure it's functional for their whole life, and that includes their communication needs, their cognitive skills, and their motoric skills. So we might be using a 25 cell so that the buttons are larger than a 60 for patients who have fine motor deficits. We then need to consider the patient's vision needs. So if we do have a patient that has a vision impairment or a cortical visual impairment, we're going to be thinking about using a high contrast user area with that yellow, red, and black. A lot of our speech generating device applications and softwares have a CVI user area that is high contrast. It's already downloaded onto the device, and that can be used for individuals who do need a high contrast. Plenty of core boards exist on the internet as well that have those high contrast icons as well. And so that's just something to continue to think about. We could also use tactile supports. I've used wiki sticks on iPads before, and I had a supervisor in grad school who used wiki sticks on a Go Talk in order to help a patient who was blind. So we get creative here, but we're using those tactile supports to help a patient access potentially a dynamic display system, but also that could mean a tactile communication system where there is a physical icon that the patient can touch, know what it means, and then exchange with the person they're communicating with. We could also consider using Braille supports. It gets a little difficult with that dynamic display, but Braille supports are a very good option for our light and mid-tech devices that have that static display. And I saw as we were doing quite a bit of research for our grand rounds that Go Talk assistive wear, I believe, is really trying to dig deep into using more Braille supports. In this area, we're also going to be thinking about that user area size and the screen size, just like we were thinking about with our fine motor deficits. This is another area. Maybe we're making the screen of the device bigger and we're requesting that 15-inch screen instead. Or maybe we are considering, listen, the best way for the patient to communicate is to have a 25 cell and to have those icons be bigger. So once we've thought about all the software and the hardware, we're ready to go forward with that insurance documentation and requesting that device. So we wanted to highlight a little bit about the requirements from the insurance companies when it comes to that trial and then the evaluation report. We must consider 3 different communication systems. Communication systems does not necessarily equal high-tech dynamic display. However, a lot of insurance companies, when you are requesting a high-tech speech generating device, want to see you trialing 2 devices. And then maybe the third would be a light or mid-tech device. Consider does not necessarily equal full trial. As Alex said previously, we don't want to impart our bias onto the patients, so it really is best practice to do at least somewhat of a trial of different devices. I agree. I fall into the rut where I tend to lean on touch chat a lot. But in order to make sure that we're not imparting our own biases of what we're comfortable with, we need to make sure we're trialing a variety of devices with those patients. That being said, we also use our clinical knowledge in these situations. So if we know that a patient is a more categorical based language processor, maybe we aren't going to be thinking about POD. So we can kind of rule out that POD wouldn't be an effective method of communication for our patient because they're not a pragmatic based language processor. They are more categorical based. So we can use that justification with our clinical rationale to state why we considered it, but we're not going forward with a POD versus a touch chat. We work with a lot of different insurance companies and they have a variety of different requirements. There's no way we can be expected to memorize all of the insurance requirements. So when in doubt, ask the company representatives, whether that's the SGD company or the insurance company. All of the companies that we mostly work with have a representative that is just dedicated to our area. And they are always available via phone, email. They'll come and meet with you in person. And they are happy to answer questions regarding the evaluation process for insurance funding. If they don't have the answer, call the insurance company. They're happy to answer those questions because they don't want you to do it wrong the first time. They want to make their jobs easier. So I have sat on the phone with AmeriHealth Caritas before, and they've answered my questions and been very helpful. Last thing we want to think about with that trial is the home and clinic trial. Not all insurance companies require a home trial. However, Alex and I both agree that a home trial is incredibly important, and it's a big piece of this puzzle. Remember that the major consideration slide, the environment, the caregivers. Doing a home trial involves all of that. A lot of times when we are requesting these devices, an insurance company will not provide another device for another 5 years. So we're locking these patients in for potentially 5 years unless there's a big medical rationale to switch the device. Because of this, we want to make sure the whole team is on board and that home trial allows for it. With that, we also want to be collecting data in the home and in the clinic with the patient to further our justification for the device. As talked about throughout this presentation, this is a multidisciplinary team. We need to have the speech language pathologist on board for that language aspect, the occupational and the physical therapist on board for the physical access portion of the speech generating device, and the parent and caregiver are such an important member of this team because they're going to be the ones implementing and working with this device at home. So that being said, a very big part of this is caregiver training and coaching. So for this presentation, we're grouping training as information that you can provide to the caregivers and the users to take home and do at home and then come back with questions. And coaching is that action in the clinic during your treatment sessions with the caregiver and the user. There's a variety of different ways we can provide trainings at home. So we can give caregiver handouts. When we're giving those handouts, we want to make sure that they're very patient-centered and they also incorporate natural teaching strategies. So for example, if you have a patient that really loves bubbles, you want to provide a handout about how to use the device when they're using bubbles, because then it'll be meaningful for the user. If you have a user that loves watching Jeopardy, you're going to provide a handout about how to use the device and model when you're watching TV. We also, at the end of this presentation, we have detailed a number of handouts that are going to be available on Teams and the H Drive that Alex and I have created. They're working documents and give us a few days to get everything uploaded, but there is going to be a myths handout included in that presentation to provide to parents. There will also be QR codes to handouts and training videos. Training videos are a really great way to help caregivers and users watch someone else edit a device or even model and implement to give themselves a model.
Okay, so now we're going to talk a little bit about coaching. And Deven mentioned that's different because the training was what you can send to the caregivers for home practice, but coaching could be real-time feedback during the sessions. And in outpatient, we can use this on that one-on-one setting. So we're going to set up a scenario where the parent or the caregiver is coming back into the session, and we're encouraging them to interact with their child with the device, and we are the observer, and then we would provide feedback in real time on how they're implementing the device, maybe some ideas of language to model, and have that discussion in a more of a coaching model where we're talking to the parent and they are the ones interacting with the patient. In this coaching model, we really want to focus on daily living and embed AAC in routines. So a lot of the times, these parents and caregivers are very, very busy, and it's hard to carry over what they see in the clinic at home. We have a lot of great equipment and toys and just treatment spaces that are controlled. And so it's sometimes hard for them to see what we do in the clinic and then think about how they could recreate it. So a good way to work around this is to think about those daily routines like ADLs, like brushing your teeth, turning on the TV, any of those examples, and then bring them into the session and recreate them with the family and the patient and really practice what you could model and make it so it's very easy to recreate create and use that at home. You can also think about those operational competencies. So we think about editing and charging these devices, adjusting the volume and the display, and troubleshooting everything that can go wrong with tech. And so we don't want to send the device with the patient and the family and not have any education happen in this area. And it can be really hard in the last 5 minutes of a session to just review this in the waiting room. And so we invite you to invite the parents and the caregivers back so that they can learn how to edit and maybe pick out some personalized vocabulary. I have parents who love to take pictures with the devices and upload specific family members and choose the voice on the device. And then you get more buy-in in that sense, and more just personalization just makes the parents and the caregivers want to use it and may motivate your patient to want to use the device more. And then again, you can consider data tracking charts. And we made a chart specifically for measuring what the parents model at home. And this requires no output from the AAC user. It is specifically just measuring what the parents are doing. What words are you modeling? And then we also have a data tracking sheet to measure what is the user using? What are they accessing at home? In anything, we want to encourage 200 models without expectation a day. And this is the idea of aided language input. And that's going to lead us to our treatment strategies. This is the first strategy we wanted to highlight because it's so easy. It's the partner modeling language on the speech stuttering device because that's what we expect the user to use. We want the output to be language on the speech stuttering device. So we're going to speak and point to symbols on the device at the same time. It's as easy as that. And we want to encourage parents to use these devices throughout the day and get to that 200 models. It might seem like a lot, but if you specify a certain amount of time within a routine or even during book reading, you could really quickly get to 200 language models in a day. Think about how many words you say in a minute. So speaking of words, we can incorporate this +1 rule in aided language input. And so a lot of the times parents ask me, well, how many words do I model or what do I model? And so if the patient is non-speaking, you can encourage modeling 1 word at a time. But then, if your patient is more at the phrase level, add 1 word to that and model 2 to 3 words. Deven and I both liked this visual to just send home the idea that we need trained communication partners. And so I've used this in sessions and shown parents, hey, we need a match here. We need the child to hear and see, they hear verbal speech and see use of the AAC device. And so then they'll start using their AAC device and they have this communication match. They're going to foster a learning environment with that aided language input. Another strategy could be the descriptive teaching model. And so this model increases flexibility of language and fosters a use of a core vocabulary. I have a lot of patients that actually are motivated to get started using their AAC device with fringe vocabulary. When we talk about fringe vocabulary, those are all the names of animals or the foods or the furniture or anything in those categories that are outside that home core page. And for example, a lot of our toys fall into fringe vocabulary. If we have a patient doing a zoo animal puzzle and they're really motivated to come over to me and tell me, like, I found an elephant, we could use this descriptive teaching model to kind of add on and help our patients conceptualize where vocabulary is on their device and specifically core vocabulary. So if my patient accesses elephant, I might be modeling big or gray or rough or heavy and loud. And now they're watching where this navigation is to get to the different folders to access these core words. And it just really helps foster more of that expressive language development. One thing in the survey that you guys reached out about was just needing more treatment strategies. So we scoured and we found this really helpful resource called MasterPal training. And this will be provided in the handouts that are going to be on Teams or the H Drive. But basically, there are a set of videos that go with each of the strategies listed here in the acronym. Today we're just going to talk about the 3 that are bolded, but I really encourage you to go and look at the videos. They're just YouTube links, and you can learn all about the motivation, statements over questions, and some of these other strategies that we don't talk about today. But one thing we wanted to really focus on was that total communication approach and accepting multiple modalities. And the idea of this is knowing that our patients' access to language can fluctuate throughout the day and depending on what they're feeling or how they are. And sometimes they might not access their AAC device. Maybe they're dysregulated and they're just using a gesture or a sign or a facial expression. We want to make sure that we're reading these cues and allowing them to communicate in the way that they need to in that moment and honoring that communication and then using it as an opportunity to model on the device. So for example, if I had a patient that was reaching to be requested to be lifted up by their parent, sometimes I see parents reach in and they really want the patient to use the device in that moment. Hit up, hit up, hit up. And it's just frustrating the patient. And what I coach parents to do is to acknowledge that reach as communication, as a gesture. And what we can do is model in that moment. Oh, yes, you want me to lift you up. Press it on the device and then carry through with the action. That is an example of honoring that total communication approach. And it really can lessen frustration and improve confidence and further use of the AAC device. Another idea is allowing for more wait time while we're cueing our patients and interacting with the AAC device specifically. I think this is a great language strategy overall, but especially with the processing that's used for AAC devices, we want to allow and foster more independent initiation. So I always say to parents, my students, awkward planned silence is okay. It is okay if there's an awkward moment because a lot of the times this can be a cue for our patients to fill it in with that total communication approach, but most of the time a cue to access that device to use their words. And then lastly, we want to talk about appropriate prompting, and the next slide will go into that in a little bit more depth. So in regards to prompting and cueing with AAC, Deven and I found this resource from Toby Dynavox. This is an updated resource from 2023. It's called the Dynamic AAC Goals Grid. It has so many things. It has activity ideas, parent letters, and then it has this whole idea of teaching how to cue for the device. And you can go through and read the flow sheet on your own. It's going to be included in our handouts. But the idea of that aid in language input being access the whole time throughout our cueing. We're always going to be modeling. We're always going to be showing them and talking to them through the device. But then how do we get them to more independently initiate on the device? We could use natural cueing, indirect cueing, and direct cueing. One thing we wanted to note here is that you won't find hand over hand prompting on this natural cueing visual. And that's because it's been found more recently that hand over hand can reduce the child's independent initiation. They might become more prompt reliant. That type of cueing is harder to fade out, and it just may affect their feelings of independence and bodily autonomy, which we work really hard to honor with more neurodiverse affirming approaches. So we just want to make sure that if we feel like our patient needs some help accessing the device, if we do feel like they need a physical cue, that we're using a hand underhand cue, and that way they can feel like they can get out of it at any time, and it's keeping that bodily autonomy. In regards to treatment, we also have to think about goals. And when we consider writing goals, we want to consider all 4 competency areas in AAC. A lot of us speech language pathologists learn this in grad school, and I think it's just a good reminder to go back to these areas when we're writing goals and making sure that we're including goals in each of these areas. The DAG3 that I referenced before was extremely helpful in coming up with goals in each of these areas. It lists goals for every type of user, and I have been using it recently, and it's been really helping me get specific with goal writing. And so I won't go through all of the competency areas today, but I just encourage you to go and look on that DAG3 resource if you're feeling stuck with goals. As always, we just want to increase AAC access within the clinic, but also within the community. So Deven and I were brainstorming ways that we could increase access within the clinic. And one thing that we have started to grow at Center Valley is our use of switch toys. And so in our handouts, we have put together directions of how to adapt a toy, a battery operated toy with a switch. And we've also included Amazon links so that you can just go and purchase and then create more switch toys at your clinic. These can be great for learning to request recurrence and just learning to start to use switches if we need that alternative access. Also, you can consider reaching out to AC companies for more long-term loader devices. And, it's company specific, but we encourage get to know the reps and then ask them if they have anything available that we can hold at the clinic for maybe 3 months at a time and trial with our patients. And then you can always try to request funding from the capital budget for more AAC apps or iPads. And then Deven and I are going to be working on an AAC clinical track, which would just help to educate more staff and help us guide our learning as speech language pathologists in the world of AAC. And then increasing AC in the community, we found that it's really, really important to collaborate with other professionals that might be on our patient's team. So a lot of the time that's a school speech therapist or another speech therapist, a home speech therapist. We want to make sure that if we're going to be getting a device from the insurance company that this patient is going to use for 5 years, that the school speech therapist knows about it and is using it in their sessions, and that they can incorporate that in the school environment. And we actually created letters that you can send to the school speech therapist or the teacher, just introducing yourself, the device, and then open the line of communication to chat and collaborate on how we can use this device across settings. Also on that note, we want to be able to collaborate with behavioral therapy, and especially in the area of appropriate prompting. We want everyone to be on the same page of what type of prompts increase independence with access to the AAC device for our patient. And we want to make sure that the prompts that we're using, the family's using, and also behavioral therapy. And we might want to keep that in mind for some of that hand-over-hand prompting.
We also, sorry, Alex, something I forgot to mention before is we want to continue with that when we are communicating across settings, is always giving that information that this is not going to inhibit verbal speech development, and that the AAC device actually helps verbal speech development. So that's something else that we want to communicate when we are communicating across settings, is kind of reducing some of those big time myths and relaying that information that this will help promote verbal speech development as well as just communication development in general.
Yeah, I feel like that is a big myth that we come across in education, especially for professionals that may not be familiar with AAC. One last thing is I really like this idea for the user to have more power in advocating for themselves and their use of AAC. So there's this idea of an introduction strategy, and it's simply programming a message on the AAC user's device that says, "Hi, my name is Johnny, and I use AAC when my speech is unintelligible." And you can practice that in the clinic. You can have them go around and introduce themselves with their device, and also that using that introduction strategy message. In closing, I love this quote: "AAC can be like magic, providing access to communication and participation for individuals who might otherwise be unable to interact with others." Has just been a really rewarding part of the field of speech language pathology for me. I remember the first time I had my first patient access a word on an AAC device, and I just got a really great feeling from that. So it can be a really, really rewarding part of our field, but we want that full success of AAC intervention to carry over across settings. So it's best evaluated not by a single performance in our therapy sessions under controlled conditions, but rather by the extent to which it improves access and participation in valued activities and experiences in everyday life. So this is a list of what you might find in our handouts. It's going to be a working document, so as we find more helpful things, we will upload it. But we have some light tech resources, some handouts for parents, those charts for carryover of data, and then information about that DAG resource that I mentioned was very helpful. If you have any questions, please reach out to us via email. They are listed here. And then here are our sources.
All right.
Thank you.
So if anybody has any questions, please feel free to either type into the chat or speak up. I do have one question already.
Oh,
And also just the note for the handouts. If anybody would like the handouts, please contact either of you guys.
yes,
So
please.
if you move it back to the.
Yes, the email.
Yeah.
There we go. Yes,
Thank you.
please. If anybody doesn't have access to the H drive or is not within St. Luke's University Health Network, please contact us. We're happy to share all of our resources.
And the Teams folder we were thinking of putting them under is going to be the pediatric Teams folder. So please reach out if you're not in that Teams channel.
Awesome. So the question that was asked is how do you determine hardware, assuming what the best hardware, when you don't have the resources available?
So a lot of times you can get a trial from a speech generating device company. So if we don't have, for example, an eye gaze device in clinic, but we think that that would be a really good opportunity for our patient to access the device better, reach out to a device company. They will send 30-day free trials, and you can trial that and you can decide against it. When you request a trial from a speech generating device company, you're not buying it. That you don't have to guarantee that you're going to use it. A lot of the companies that do like mounting as well as wheelchair access are very happy to help and provide samples and come to the clinic and help. So when in doubt, reach out to these device companies and reach out to multiple. So if you're not quite sure yet which will be the best fit, get a few trials and trial them out. Usually just have to send them back within 30 days. But it's out there and it's free. It has no cost to us or the patient.
And if you need help with determining what companies to reach out to, you could email us
Yeah.
and ask. I know Deven has worked a lot with mounting and we can problem solve, and those companies are always changing too. So if you need some help, you could always ask us.
Awesome. And a follow-up to that is any thoughts on how to ship it back without it being too costly?
Usually they provide a label to ship back.
Mm-hmm.
So usually for the devices, you'll get the box and it'll have a return label in it. UPS,
Yeah.
Postal Service, goodbye. You can even set up one of the companies, you can call FedEx and they'll come to the clinic and pick it up for you. So,
Awesome.
yeah.
Any other questions? Well, if you do think of anything else, please feel free to reach out. We'd be happy to answer them.
Yeah.
Thank you
Love
guys
talking
for
about it.
attending, and please make sure that you complete your quiz and your course evaluation. Thank you.